The first thing is it's very important to understand the nature of insurance and insurance risk and why it's bad for healthcare. This is kind of the root of many of our problems with healthcare. Insurance is a system for managing financial risk, and it's designed for risks that are infrequent, expensive, and unpredictable, like your house burning down from a lightning strike, or getting into an accident and having an untimely death, or things like that. And if the risk does meet those three criteria, infrequent, expensive, and unpredictable, then the main way risk is managed is with risk pooling, where everybody contributes a monthly premium, even though they don't need the help very often. And then for the few people who have a disaster that happened to them, the money is there to cover it. And you spread the risk across a large population that's mostly low risk in order to cover the risk for a few people with an expensive, unpredictable problem. To the degree that the risk is predictable, then insurance companies use underwriting and actuarial analysis to try to identify that risk so they can either charge more for it or refuse to cover it, which undermines the whole purpose of health insurance. The problem with healthcare is that way too much of the risk is predictable for this model to be appropriate. Too many people have pre-existing conditions, or you can tell by their demographics how likely they are to get sick, or you can tell by their zip code and their socioeconomic condition how likely they are to have expensive health problems. So there's all kinds of predictable risk in healthcare. So the result is that if you leave the insurance business model to do its thing, they're going to be focused on avoiding risk, excluding sick people, denying care, all the things we complain about, which are built into the business model. And if you don't want all this denial of care, all this risk avoidance, you shouldn't be using the insurance model.
I'll move everybody.
Hello.
So if you have, let's say you have several insurance plans in an area and a new one comes in, if they were to actually offer a better plan, the doctors would find out about it pretty quickly because they're the ones that deal most directly with insurance. And they would tell their patients, oh, this is a better plan. And of course, their patients are the ones that seek healthcare the most, they're the most expensive to care for. They would all sign up for this new, better plan. It would get stuck with a sicker risk pool and end up going bankrupt. So you have a situation creating a race to the bottom, where if you want to compete in the insurance industry, you've got to be no better or a little worse than the competition, or you're going to get killed financially because you'll get stuck with all the sick people. So whoever bears insurance risk is who has the money and is stuck with covering the variability and unpredictable of healthcare costs. Also, whoever bears insurance risk has the opportunity to make money or lose money off of healthcare. So if an insurance company says, okay, you pay us a fixed amount of money per person and we'll cover the risk, and they manage to avoid sick people, deny care, or what they claim is they're going to be more cost effective, but actually what they're doing is avoiding sick people and denying coverage. But anyway, if they succeed in spending less than the amount of money they got capitated with, they get to keep it. So there is a profit incentive. Even if the insurance company is technically not for profit, there's a profit incentive built into the model of being capitated, which means you're being paid per member in exchange for an obligation to cover the healthcare needs of the population covered. So any payment scheme that holds the provider of care accountable for the cost or outcome of care for a fixed amount per person is a risk-bearing entity. Social insurance is pure risk pooling, which says, okay, we're not going to use a competitive insurance model. We're going to include everyone in the whole population. Everyone contributes through taxes. And the only way risk is managed is risk pooling. And there is no underwriting, no cherry picking favorable risk pools, no exclusion of high risk patients, no gaming of documentation to beat risk adjustment formulas, et cetera, et cetera. Social insurance is pure risk pooling, and that's what single payer is intended to be. So an optimal single payer bill should include one payer that pays providers of care directly with no subcontracting and funding to risk-bearing middlemen, like HMOs, ACOs, and IDSs. We'll get to how you can accommodate a system like Kaiser, which has some positive aspects without it being a risk-bearing entity later on. But you need one payer that pays providers of care directly. You need budgets for institutional providers of care instead of having them bill fee-for-service for every Band-Aid for $10 each and things like that, which happens now with hospitals. So hospitals, nursing homes, federally qualified health centers, they get a budget that's enough to cover their cost of operations, but not enough to build a chain, an empire chain, not enough to retain profit, not enough to pay corporate chain management, but enough to run their operations. And this is not a fixed amount where if they deliver care for less than that, they get to keep the difference, which would make it profit seeking. It is a budget based on the cost of providing services, exactly like the way we fund police departments, fire departments, and other necessary government services, where you pay them a budget. You pay the police department a budget, but if they have some kind of disaster and have to pay the police a lot of overtime, they're not going to lose money. They're going to ask for a supplemental appropriation. And if they have money left over at the end of the year, they're not going to keep it as profit. It gets plowed into the next year's operating budget. So it's not designed to make money or lose money. It's designed to cover the cost of operations. We should be paying all institutional providers in this way. For independent physicians and other healthcare professionals, we need a simplified, standardized fee schedule that's predictable, where a doctor knows if they do this amount of work, they're going to get paid this much. They can figure out what their overhead is, and they can operate a small business because the payment is simple and standard. And you need negotiated price controls for drugs and durable medical equipment. Those 4 features are for an optimal single payer bill. Something like traditional Medicare is a suboptimal program because it does pay providers of care directly, and it does have a standardized fee schedule, but it's no longer simple. It does not pay institutional providers with budgets, and it doesn't negotiate price controls for drugs and durable medical equipment. So it's got some elements of single payer, but not all of them. So what's the difference between capitation and a budget? Capitation conveys risk, which means there's a fixed payment and you can make a profit if you deliver care for less than that amount of money. And you can't keep unspent earnings and do other things with them than run your operations. And with capitation, there is an incentive to restrict care, to cherry pick and lemon drop. It's all the things that I said are problems with the insurance model. You're being paid like an insurance company if you're being paid with capitation. So like they've capitated primary care doctors here in Hawaii. And the only ones that are making it with capitation are the ones that have large, stable practices of mostly middle-class patients. So they have lots of capitation payments because the practice is large. They don't have to work too hard because they're a relatively well-to-do population with few complicated problems. If a practice has largely Medicaid patients, they're going to go bankrupt with this formula. And capitation requires risk adjustment. So the supposed solution to this problem is, okay, we'll analyze how sick your patients are and pay you more if you take sicker patients and less if you take healthier patients. So that will counteract the incentive to cherry pick and lemon drop. The problem is that risk adjustment formulas are quite crude. The best of them, the ones most widely used, capture about 12% of the variability in cost, which means there's a remaining 88% of the cherry pick and lemon drop. So it fails to solve the problem because you can't make it accurate enough. And if you try to make it more accurate, that requires very detailed data, and the cost and the burden of trying to gather that data becomes prohibitive. And so the whole idea of let's see how close we can get to predicting risk by using a risk adjustment formula stalls out at about 20% prediction. And beyond that, it fails because it's pushing a rock up a vertical hill. It doesn't work. So you can never get adequate risk adjustment to solve this problem. And this is what the insurance people will all say, oh, we'll just risk adjust so that we don't have this problem. It can't get close to solving the problem. Whereas in contrast, the global operating budget does not convey risk or offer an opportunity for profit or loss. So payment reforms in this country, starting with HMOs and managed care movement in the 90s and put on steroids by the Affordable Care Act and value-based payment. The rationale is that excessive US healthcare costs is explained by unnecessary care due to presumed financial incentive under fee-for-service to maximize volume of care. And if fee-for-service is the problem, and if it's driving doctors and hospitals to deliver a lot of unnecessary care, and if this explains the high cost of US healthcare, then flipping the incentive and using capitation, so you have to deliver care within a fixed amount of money per person, should counteract that incentive. And that means shifting insurance risk onto smaller and smaller entities. So you're making a doctor hospital group or even an individual primary care practice into a little insurance company that gets to keep money by denying care or avoiding sick people and loses money if they take on too many high-risk patients. The other thing about shifting risk onto smaller and smaller entities is that risk management requires big data. If you are going to be taking on patients and you're being paid with capitation, you need to know how risky they are, and that requires lots of data on their demographics, their pre-existing conditions, their zip code, all these things that affect risk, so you can try to avoid risk and play the insurance game. The fact that risk shifting requires big data means that you need the insurance industry, because they're the ones that can generate and manage that kind of data. So it's a way for the insurance industry to entrench themselves in healthcare by promoting risk shifting. So the first wave of this was managed care and capitation in HMOs in the 90s, but there was a backlash against the incentive to skimp on care, and it died down somewhat, but not until after really jacking up the cost of administering healthcare. Then in the 2000s, we had pay for performance or outcomes and quality metrics, which are a first step to prepare the way for risk shifting. Okay, to pave the way for risk shifting schemes down the road. And that is in the form of value-based payment and accountable care organizations, which are paid with capitation, or bundled payment, which is another form of risk shifting where you pay, say, a hospital and an orthopedic surgeon and a nursing home and any ancillary staff needed to help care for the patient, a fixed amount for a whole episode of care, like a hip replacement. So if you're an orthopedic surgeon combined with a hospital and others taking on a hip replacement patient, you're paid a fixed amount of money. But instead of being incentive to be more cost-effective in delivering care, this becomes an incentive to only take on low-risk patients and avoid high-risk patients. And that's what's actually happening. So any kind of risk shifting will have these kind of perverse effects and aggravate disparities in care. And then value-based payment is all of these things, and is being pushed in the Affordable Care Act and by Medicare. So an HMO, this is what's the difference between an HMO and an ACO? An HMO is an integrated system of a multi-specialty physician group or affiliated independent practices and a hospital or hospitals, which assumes responsibility for the healthcare of identified subscribers and enrollees, takes on insurance risk. And enrollees know they're enrolled in a plan. So this is like Kaiser, where you signed up for an HMO plan, and with Kaiser it's a closed panel plan. With the independent practice HMOs, you do sign up for it when you buy the insurance, that you're going to be in an HMO plan, which means you're limited to a more restricted list of doctors. But enrollees know they're in the plan. If it's closed panel, that would be like Kaiser. And Medicare Advantage and Medicaid managed care plans are also HMOs, where you have an insurance company and you have payment per member, and you have an obligation to cover the care for those members for that amount of money. An ACO was created by the Affordable Care Act, and the difference is that an ACO does not have members that signed up for it. They have members that are attributed based on where they seek care most often. And the patient may not know they're attributed to an ACO. So let's say you see a particular primary care doctor, then that doctor would be attributed to your life, and they would get paid a capitated payment for you. However, if you switch primary care doctors in the middle of the year, or if you see one doctor for one thing and another doctor for another, then this creates all kinds of complications of trying to figure out who that patient should be attributed to and who should get the capitated payment. And so once they are attributed, then the doctor is paid with capitation or partial capitation, which shifts risk onto the doctor. And this requires quality metrics, pay for performance, risk adjustment, detailed documentation, data reporting, and high administrative costs. The reality is that utilization of care in the US is toward the low end of industrial countries that cover everyone for half what we do, and they often use fee-for-service. There is no evidence that I've ever seen of excessive utilization in primary care paid with fee-for-service. There is evidence of pushing unnecessary care by hospitals, especially if they're for-profit hospitals, and certain procedural specialists, but I've never seen evidence of primary care driving up costs by doing unnecessary things due to fee-for-service. And of course, when you shift risk, you have incentives to skimp on care and to cherry pick and lemon drop. And if you add, the idea of pay for outcomes was that if we pay for outcomes, it's supposed to deter skimping on care. So we're paying you for good results, not bad results. But what that does is it really exacerbates the incentive to cherry pick, because you can get better results from an easy patient than you can from a difficult patient. And if you're being paid capitation, you have a strong incentive to avoid the difficult patients. Of course, risk adjustment doesn't work. So if you try to use market forces to control prices, which the US is completely sold on this idea, but we need more competition. We need market forces to control prices. This results in huge administrative costs, 5 to 6 times that of public systems or of other countries. The incentive is to avoid risk, the race to the bottom among plans, misguided and costly efforts to manage healthcare providers through bureaucracy, and no one has ever saved money by using competition in health insurance. Doesn't save money, doesn't reduce costs, it doesn't add value. This is the famous PNHP slide, but I'm showing it because this is the managed care bump from the 90s. So when we went to managed care and HMOs, we saw a huge rise in the number of managers in healthcare and not much rise at all in the number of doctors. And the bump at the end is the value-based payment bump since the Affordable Care Act, which is seeing another sharp increase in administrators in healthcare. So this is where the money is going. So there are quite a few single payer bills that try to accommodate systems like Kaiser and HMOs and accountable care organizations, because they have bought into the idea that this is a way to control costs, or integrated delivery systems. So these are going to deliver more coordinated care that's going to be less expensive. And that therefore, these proposals, although they're intended to be single payer, allow for shifting insurance risks onto competing risk-bearing entities, perpetuate the competitive insurance business model, and are Trojan horses for the insurance industry. All these HMOs and ACOs cannot manage insurance risk, which means avoiding sick people, unless they have the data, and they need the insurance industry for that data. So examples are Bernie Sanders, the S1129 has an HMO ACO loophole and no budgeting of hospitals. The New York Health Act does, Healthy California Act, SB 562. There are a couple of other bills that attempt to, they claim they're going to budget hospitals, but they also allow for capitation. So I'm not sure how they think that will work, because if you're paying a hospital an operating budget, then there's no room for, if you're going to pay them with capitation also that covers hospital care, you're going to be double paying the hospital. And you could theoretically capitate doctors, but not hospitals. And maybe that's what they have in mind. But then you have the whole problem with incentives to cherry pick and lemon drop and avoid sick people being pushed onto doctors. The bills that are true single payer bills that have no HMO ACO loopholes and do have global budgeting of hospitals are Jayapal's HR 1976 and the California Guaranteed Healthcare for All Act AB 1400. Those are true single payer bills with no loopholes. So the arguments for ACOs and capitation, and there are some, because if a doctor is paid with capitation, they have flexibility in how care is delivered. Or if a group of doctors in a hospital is paid with capitation, they might be able to do creative things like if a patient is in and out of the emergency room a lot, they could free up the money to pay for an air conditioner to keep them from getting frequent pulmonary problems and heart failure and reduce their hospitalization, reduce healthcare costs. So there is flexibility in how you spend the money if you're being paid upfront in capitation. For a doctor, you can, during the pandemic with COVID-19, doctor visits went way down, but if you're paid with capitation, your income stays the same. Your income stays the same because it doesn't depend on the doctor visits. So that's an advantage of capitation. And it enables the doctor to use more lower level practitioners in their practice to try to expand the number of patients they can cover. You can free up funding streams for care coordination, and you can have more predictable budgeting. However, there is more predictable budgeting, but let's say you're capitating an insurance company or an HMO, and they find that the capitation rate is not high enough to cover their costs and they're losing money. They can then come back to whoever is paying, usually government, and say, we need a higher capitation payment for next year because this isn't covering it. They can demonstrate that they're losing money to the insurance commissioner, who will then support it, and they end up being able to dictate how much they're going to get paid the following year. So you make this year's budget fixed, but you lose control of next year's budget and the next year and the next year after that. And from there on, these risk-bearing entities are controlling how much they're getting paid at government expense. The argument against ACOs is the high administrative costs. The capitation rates often they're based on previous fee-for-service utilization and fail to account for the administrative costs of the ACO model. They exacerbate disparities in access to care, and they incentivize cherry picking, lemon dropping, and taking on more patients than the doctor can manage and still provide quality and attentive care. And they also deter new practices because until you get that large stable practice, you're going to be losing money with capitation. So what to do about Kaiser? The solution with Kaiser, I mean, Kaiser has been pushing for HMO loopholes and single payer bills so that they could maintain their business model. And they claim they're a three-legged stool with a doctor group, a hospital, and an insurance plan. And you need all three legs or the whole thing falls apart. And if we don't maintain Kaiser, then everyone who's got Kaiser is going to lose their health care. This is what they're saying. Now, the solution in HR 1976 and AB 1400 in California is that a multi-specialty physician group practice can affiliate with a single hospital and be paid through that hospital's global budget. So the hospital will get an operating budget to cover hospital operations and the salaries of the doctors, all in a single budget. And they can then share, their real estate site. They can share, their operating overhead, and they can share their electronic health record. But there would be no money in that budget for chains, for corporate management of chains. There'd be no money, no allowance for retained earnings or profit. So again, it's like the police department. If there's money left over at the end of the year, it gets rolled into the next year's budget. And if there's a shortfall, they can ask for a supplemental appropriation, but there is no expectation of profit or loss or allowance for profit or loss. And any necessary capital expenditures would be funded separately by the single payer according to community need and not based on a hospital joining a chain and accumulating money for capital expenditures and also for profit and whatever other purposes that are contrary to healthcare. So this gives social control of healthcare resources so that they're allocated according to community need. So you don't leave it up to a chain manager to decide whether a new clinic will open or a new hospital will be built or a new MRI facility will be installed. It's decided according to where in the community they're needed. Now, as the other argument for ACOs and HMOs is that they will coordinate care. I find this, this argument is widely used. A lot of people believe it. I find it particularly hard to swallow because from what I can see as a doctor practicing in a Medicaid clinic, the obstacles to coordination care are fragmentation of Medicaid into multiple competing plans more than anything else. They all have narrow networks or doctors won't take them. And you can't coordinate care if you don't know who will take the insurance. If all doctors took the same insurance and you felt that this patient needs a particular specialist, you could call them up and ask them to take the patient, and they probably would. But if the system is fragmented into multiple competing plans, each with a narrow network, the doctor can no longer coordinate care and must turn to the insurance companies to say, well, can you find someone that's in your network? Because I don't know who's in your network. And so they're the ones creating obstacles to coordination of care and claiming that they're there to coordinate care, which is extremely perverse. There are beneficial services like teams, interdisciplinary teams to handle high-risk special needs patients, such as ER frequent flyers or complex patients that are trying to be managed in the home to keep them out of the hospital, where you need visiting nurses, you need an interdisciplinary team involving both physicians and community workers and nurses who can follow the patient and follow them closely and make sure that they're getting all the care that they need. Those kind of programs are beneficial, and there's no reason they can't be funded directly by a single payer with a global operating budget, instead of hiring a middleman, an insurance company, who then claims they're going to do that and often doesn't do it as much as they claim they will. Why not pay for those things directly by the single payer? It's more cost effective and it works better. And then those services become a community resource that any doctor can tap into based on patient need, instead of something that's proprietary to a particular health plan. I've been involved in a model called collaborative care, which is psychiatric consultation to primary care practices, which works very nicely. But if it's funded by insurance plans and limited to each insurance plan, then every time the patient changes plans, which happens a lot with Medicaid, they lose their team and have to start all over again with a different team. And it doesn't work very well. If it's set up as a community resource paid by a single payer, or a single Medicaid program, and any doctor can use it based on patient need, it just works better. The same is true for quality improvement programs. They should be based on professional motivation to serve their patients, not pay for performance schemes and financial incentives, which result in corrupting intrinsic motivation to do the right thing for patients. Any necessary administration should be funded with non-risk administrative services only contracts that do not involve capitation or risk shifting. In other words, the administrator who is hired to do claims processing, administrative support for quality improvement, credentialing, things like that, they're paid to do those services, which are generally done by insurance companies. A single payer can pay one entity to do those things, not on a competitive basis, not capitated, but based on what it costs to do those services. When Connecticut switched their Medicaid program from managed care to an ASO contract, for their Medicaid program, their administrative costs went from 20 to 25% down to 2.8%. This is far, far cheaper way to cover the necessary administration for a healthcare system. So a good single payer bill must ban HMOs, ACOs, and capitated integrated delivery systems, not use capitation, case rate payment, bundle payment, or other forms of value-based payment, not use pay for performance based on cost or outcomes of care, and ban duplicative coverage from other sources for essential benefits covered by the single payer. Then you have a good single payer proposal. Questions?
Steve, I have two quick questions. One is how do you integrate a comprehensive data system in the checkerboard of global budgeted entities so that no matter where you go, you can get at the information wherever you're being taken care of? The second question is, I'm keenly interested in how to nail down pay for time and insert that into our legislation. You know, and I don't know quite where and how you would fit that into the narrative here in terms of the creation of the policy.
With your first question, if you have a single system for a community or a region, then that system would presumably all use the same electronic health record. And anyone who needed a referral for specialized services within that community or system would be able to use any provider capable of delivering those specialized services. So the key there is not having fragmentation into competing systems, but having one system. If you rely on risk shifting, you need competition. If you pay an insurance company a capitated premium, and they're the only insurance company in an area, they have complete control over what they can demand from you.
I understand. I'm asking a different question. I'm asking a different question.
Okay.
No matter where somebody goes, they have a card, and that card has to be able to bring up their story. And depending upon whether they're a Kaiser person or a Sutter person or whatever it is, how do you insinuate that universal data system that services the entire delivery system? This isn't an issue of competition here. I just don't understand how to be able to manage information about everybody, anywhere, anytime.
You would need to, first of all, require that all of these systems use the same electronic health record. Here in Hawaii, we've got Medicaid, we got, the two major hospital systems and a lot of independent doctors. And both the hospital systems and Kaiser all use Epic. 3/4 of the independent doctors are now using Epic. And we can access, if our system is using Epic, we can access the records in any other system using Epic. And this is already happening. And we occasionally run into the 25% of practices that are not using Epic and have to get faxes or paper charts or things like that. Yeah. But for the large majority, because they're all in Epic, and Epic allows transfer of information with HIPAA protections, you can make that work. So if you have a single payer system, it ought to be pretty easy. I know that there are other countries, I've heard they do this in France, where your individual medical information is encoded on a smart card that's your health insurance card. And whenever you go to a doctor, they swipe the card and they can get the information they need. Yeah. At the end of the visit, they swipe it again and put it into the system. And it makes both billing and collections super simple. And it also gives the patient an electronic health record that follows them wherever they go. If it's done elsewhere, we can do it here too.
Gotcha. And the fee for time?
Fee for time is an idea that I've been working on for a long time of how to pay doctors, where instead of paying for procedures the way that the RBRVS resource-based relative value scale does, which is a system for calculating the value and therefore the price of each individual procedure, you just determine the time needed for each procedure and you pay the doctor for their time. And this would pay doctors based on their time and expertise instead of on the presumed value, inherent value of a procedure. When you're paying for a procedure, it's very easy for a health plan to say, well, if we're paying for a tonsillectomy and an advanced practice nurse can do that too, why should we pay a doctor? Because there's no value placed on the MD or on the training that the doctor had. The value is presumed to be inherent in the procedure. Every other highly educated profession is paid for their time and expertise. Lawyers, engineers, architects, they're all paid for their time and expertise. Salary doctors are paid for their time and expertise. The only exception is US doctors paid with fee for service are paid for a presumed value of a whole bunch of procedures. If we were to standardize everything based on time, we could save a lot on administration, and we could rectify the discrepancy between pay for procedurists and pay for generalists and primary care doctors, because you base it on time and you base it on the training required for that specialty, and that's it. That's the idea. I don't know that this needs to be spelled out in a bill, because it's the kind of thing that you would work out. If you agree that you're going to pay fee for service, then you would have to answer the question, well, how are you going to do that? And this would be a recommended way to do that, but it could be set up in the rules. It could be modified as you go along. It doesn't necessarily have to be in the bill, but I do think it's a good thing to have in the back of your mind as a more efficient way of paying doctors, a fairer way of paying doctors who are not on a salaried basis, who are in independent practice.
Is there a reason not to put it in bill language?
The thing is that it would, you could, but I would want it to be renegotiated at regular intervals with collective bargaining. I think, Canadian doctors are authorized to bargain collectively with the government for their rates. And that has balanced the interest of doctors to maintain adequate pay with the interest of the public and the taxpayers to keep costs down. It's kept those things in balance. And the result has been Canadian doctors are generally pretty happy and they're paid adequately. Other countries that don't have collective bargaining tend to underpay their doctors, and then you end up either compromising your physician workforce or forcing doctors to make money in other ways. Like in Japan, they're paid a pittance to see the patient, but they can make money on the side by selling them their drugs. So you need to work around to allow doctors to be paid adequately to stay in business. And the best way to do that would be collective bargaining. So I think if you specify collective bargaining and say we're going to be paid based on fee for time, that would be the nice way to go. But you have to educate people on what the model is before you can persuade them to put it in their bill. So that's the difficulty.
Next is Barbara Commons.
Yes, hi. Thanks very much for this presentation, Stephen. It's great. I'm a ship counselor in California, and I have a question about the payment. I'd like to educate my people about how their healthcare is funded. So I understand Medicare capitation and fee for service. How does it work with Medicaid, Medicare? If someone's getting both and they're Medi-Medi, would that be fee for service? And then managed care would be capitation. Is that right?
Well, generally you have blended situations where originally Medicare and Medicaid were both straight fee for service. And with HMOs, they become partially capitated. And with ACOs, they become more partially capitated, but they're still partly fee for service and partly capitation.
Okay.
It's very hard to do full capitation without creating huge problems, which is what's happened with primary care here in Hawaii. But most of these are a blend of fee for service and capitation. In Hawaii, Medicaid is still entirely fee for service, but they're trying to move to capitation. But they've already driven the doctors, the managed care companies have driven Hawaii doctors out of Medicaid. And if they start capitating, that will just be the last nail in the coffin for independent practice taking Medicaid. So, I mean, they may do that, but it's like you're paying insurance companies to manage care, but no doctors to actually deliver it.
Right. And if they are managed care, meaning they are capitated, is there a percentage that the federal government puts in toward the capitation, and then the state government, another part of it?
Okay, let's talk about where the capitation is, because already capitation is at the level of the managed care plans. And Medicaid is a joint federal state program. It was initially about 50-50, but it's adjusted so that poorer states get more and richer states gets less. So, and then the Affordable Care Act expanded Medicaid almost entirely federally funded. So it's in practice, it's about 60% federal, 40% state for Medicare funding. And that is capitated to the plan. What's going on now is the plans are wanting to push that risk down onto doctors by capitating doctors. And that's where we're seeing the destructive effects on the healthcare delivery system.
Right, thank you. And will your slides be available to people?
Sure, I can put them in the chat. Let's see, I'm gonna stop screen sharing. I'll put the link in the chat and I can also send it to Mike afterwards.
Okay, great. Thank you so much.
Judy Rice.
Just a little bit about the medical records.
Yeah,
Basically, I worked with Meditech for years and years, and St. Joe's put it in, whatever. But I also am a family historian, and you've got GenCom. It's a generic program. I can take my data and put it from Family Tree Maker into Roots Magic and basically not lose data. There's a way to do it so that you don't have to worry with whether you're Epic or anything else. We can find the system to do it. But one of the things I really haven't heard talked too much is my whole vision of healthcare becomes transformed by the medical record, by all of that stuff. I take my blood pressure at 7:30. I give the blood pressure pill at 8. I might give 8 of them or 3 of them. I think over time, we're going to start determining which pills are effective, which pills aren't, whether you give them all at one time, whether you space them out every 2 hours. I think there's so much siloing of information by insurance companies that we don't know where there are clusters of cancer, clusters of kidney failure, clusters of asthma. All of the things that are detriments to health are siloed off into proprietary systems. And until we share that data, we're not going to have a healthy community.
I agree with you. This is another area where health plans claim they're coordinating care and they're actually interfering with coordination of care by getting involved in telling doctors what they can and can't prescribe. For example, there's a commonly used antidepressant that has a short half-life. And there's a syndrome called SSRI withdrawal syndrome where you get dizzy, sloshy feelings in your head and zappy electric shock sensations when the medicine starts to wear off. So some people get that if they're taking it once a day. And so if you divide the dose, then it smooths it out and they don't have that problem. But then you get the health plan saying, we're only going to authorize once a day dosing.
Exactly.
So that kind of interference prevents doctors from trying something innovative. Or another example is you can use some of the antihistamines for other indications than just allergies. And this is something that's off-label use of drugs. Doctors can use a drug for something other than what it's been approved for by the FDA and discover that it's helpful. But if the health plan says you can only use it for its FDA approved indication, then you block innovation. And the result is we're crippling our ability to innovate and to experiment and to try new things because of reliance on insurance industry siloing, as you said.
I asked you about is Kaiser because I was a Kaiser doctor for 30 years plus. And it's kind of a black box to me as a Kaiser provider, how we ended up getting our paychecks, of course. But what isn't is that third three-legged stool concept, which, to me is, I guess it is a little bit of a black box because, the one leg was the provider group, the one leg was the hospitals, Kaiser Foundation hospitals, which actually included other providers and not just physician providers. So you had nurses, technicians, others would fall under the hospital leg of the stool. They would manage all of those other employees. And then the third leg, of course, which you mentioned was Kaiser Health Plan. But of course, the health plan had all the other business operations that would then allocate resources to both hospitals and the provider group, meaning Permanente provider group. So, so it is complicated that way. I always thought of it, for simplicity's sake, as taking the insurance function out of the third leg of the stool, but still having business operations in that third leg of the stool. So you could still have, however, that large a group model practice then would, say, request, as you said, supplements to their whatever their budgeting is, or adjustments for their budgeting, and then obviously distribution of resources within their group model practice has to be controlled by some entity. And I would presume that's the case for other large group models, like say universities or non-HMOs. I don't know if say like the Mayo Clinic or Puget Sound or groups like that operate similarly, or are they also HMOs? I guess that's kind of my question to you. And then second
yeah.
question I have is about these HMO carve-outs in these bills, and especially in California, we kind of have this internal squabble going on in our coalition. And I'm wondering who are they trying to protect by doing one of these HMO carve outs, or if from your insight as to that thing, that HMO carve out, how can we better understand so that the groups all working toward the same end of a single payer system can kind of figure out our differences?
Okay, good question. The idea is that the argument is that Kaiser is not a three-legged stool. It's a two-legged man with a tail. And if you eliminate the insurance function, which is the tail, but you do everything necessary to preserve the doctors, the hospitals, and the way they work together, you only eliminate the insurance function. What that means is that you no longer have a closed system with members, and therefore it's not being paid per member capitation. So it eliminate members, and it would make Kaiser doctors and a Kaiser hospital an integrated system to deliver care, but there would be no members, and it would not function as an insurance plan. And that means any Kaiser patient could see any other doctor they wanted to in the community. There would be no such thing as surprise medical bills for going out of network. You wouldn't sign up for Kaiser. You would just go there if you liked the doctors there or wanted care there, because it wouldn't be a closed panel anymore. The closed panel is a function of the insurance, it being an insurance company. If you take the insurance leg out, it's an open system designed to deliver care that includes both the hospital and doctors. You would want to divide Kaiser up into separate hospital physician groups or systems. So each Kaiser hospital would have a group of doctors affiliated with that hospital that would pay those doctors through their operating budget, which has been expanded to include the doctor's salaries. If a doctor in one hospital is used to spending 20% of their time consulting in another hospital, let's say they're a specialist, and Kaiser uses them in several hospitals, either that doctor could be paid through one hospital's global budget, that's their full salary. If the hospital wants to let them consult somewhere else, that's fine, but they're already paid for. You don't need to worry about how to pay for it. Their pay is covered. They're getting their salary, and they can consult wherever they're allowed to consult. Or you could have the other hospital pay a portion of their salary. There's different ways you could work that out. But the idea is that you're not locking in members or paying per member anymore. You're paying the cost of running the operations and paying the salaries. And then a lot of the difficulties with Kaiser go away. You don't have any funding stream in that for a corporate chain, for a corporate office that's managing multiple hospitals. The hospital, each hospital has to have a hospital administrator and a hospital administration. That's necessary to running a hospital. So that would be included in the hospital's global budget. But the idea of a chain that is trying to capture money from all the care that's scattered through the system so that they can build their empire and buy another hospital or build another hospital, that would go away. There'd be separate budgeting for capital improvements like new hospitals from the single payer based on community need. But there would be no opportunity for Kaiser to build an empire. Each hospital and doctor group would get its own budget.
What did Connecticut do to cut the administrative costs of its Medicaid program by 90%?
That's a terrific question. And the answer is the insurance companies are able to hide large amounts of administrative costs by disguising them as healthcare. The Obama administration negotiated with America's health insurance plans in 2011 to include anything that they call medical management or quality improvement or payment reform as healthcare in reporting their medical loss ratio. So they are now free to spend as much money as they want doing creatively destructive payment systems, pay for performance systems, anything like that. And they get to call it all healthcare, even if it's administration. So they're hiding huge amounts of administrative costs in their healthcare budget now. And David Himmelstein and Steffi Woolhandler did a study where they looked at a bunch of health plans, and it was very difficult to get financial information out of them because it's proprietary information and they're very secretive. But they managed to try to extract enough to get an idea of how much was being spent on medical management. And when you added that to their administrative costs, they hadn't gone down at all since the Affordable Care Act. The Affordable Care Act supposedly limits large insurance companies to 15% administration and smaller ones to 20%. It's actually more like 30% because a whole bunch of it is being hidden as healthcare. That's where it was all hiding. In Connecticut, they did freedom of information inquiries. They forced the state to say, well, the insurance companies are spending state money, so they can't call this proprietary. They have to release the data. They're able to show that a bunch of money was being hidden. And when they actually implemented it, it turned out that there's a cost. First of all, the risk of the total cost of healthcare goes up and down every year. And if the state is taking the risk, the state pays the average of those ups and downs. If the insurance company is taking the risk, they're going to charge the top end of those ups and downs. So there's a premium right off the top for the insurance company taking risk. You add that to all the money hidden in healthcare that's really administration, we're talking about large bucks, and that's where the savings are. Yeah, that's where the 90% savings are. Those two things.
Stephen, I think you would agree that every method of reimbursement has pros and cons, has some bad incentives mixed with whatever incentives serve the interests of whoever the stakeholders are. And I think that it would be really helpful to take the information on your slides, which is quite detailed and thorough, and put it into a very simplified matrix, which lists for each method of reimbursement the principal pros and cons. And I think that you also ought to do that for fee for time. So fee for time, obviously, intuitively, looks like it would have some incentives that would not be beneficial. And I think that, those deserve mention.
Okay, I agree that there's no such thing as a perfect payment system, but I've been interested in the question, even though it's not perfect, what's the closest we can get? Because obviously there are better and worse payment systems. And so let's get as close as we can to a perfect payment system. And my ideas about that are it should be as incentive neutral as possible so that we rely on an intrinsic motivation for decisions about healthcare instead of financial incentives. And it should be perceived as fair by the people using it. And Canada has come fairly close to this, and they're not using fee for time. They do pay for procedures, but they have collective bargaining, which helps a lot. The advantage of time-based is that you use time as a common denominator to resolve the problem of overpayment of specialists and underpayment of generalists and primary care doctors. And you base it on time and years of training, which it's true that some procedures may require a lot more stress and effort than others, and you're not accounting for that. So that's a drawback to paying that way. but its advantage is that it's simple, it's straightforward, it's objective. So if you're using RBRVS and you say how much physician time, how much physician stress, how much physician effort, et cetera, goes into this procedure so that we can calculate a value for the procedure. Everyone claims that their procedure is more stressful than somebody else's. They're all jockeying for position. The specialists on the RBRVS update committee tend to dominate. And so it gets skewed anyway. And it's not objective. It's too easy to corrupt it. Whereas if it's based on time and years of training, those are things that are hard to argue with because they're very concrete and objective. So I like allowing a certain amount of unfairness because overall it's simple, easy to grasp, and objective, and eliminates a lot of arguments. So that's why I like the idea.
And one quick follow-up is, are there examples of fee for time that you can share?
The biggest example is the way psychiatrists were paid in the US up through 2012. We were paid fee for time. So I was paid this way for many, many years, most of my practice, and it worked fine. And yes, some patients are more stressful than others, and the payment system doesn't accurately recognize that. But everybody kind of rolled with that and accepted it. And you still took on difficult patients, and you might put in extra hours on some people that you didn't get paid for. But it was close enough to fair that it worked. So I know that it can work. They also do pay doctors directly this way, primary care doctors in Switzerland. They're paid basically the same idea that I've been putting out a fee for time. And it seems to work well there and doesn't result in a lot of problems that you could say theoretically, what if this, what if that? But in fact, it seems to work pretty well in practice because it's close enough to fair that everyone's willing to buy into it.
So I just wanted to make sure, I'm glad to hear what you just said about primary care. Our daughter was married to an interventional cardiologist, and I said, you know, primary care doctors should be paid at least as well as specialists. And she said, but all of the training he went through. I said, that training should be rewarded by the fact that he doesn't have to do primary care. So I'm glad that at least in Switzerland, primary care is fairly treated. It seems that a pay for time and expertise might undermine that.
Well, it would undermine that to some degree because what my proposal would pay specialists more than primary care. But what I would do is I would stack the fee increases, the annual, the amount of increase per year of training toward the first few years, and then narrow it down in subsequent years so that you would get paid a lot more for getting 3 years of training than 1, but only a little more for 4 than for 3. You know, so each additional year would get its own increment, and the increments would shrink as you went up, so that it would not be so skewed. But I've also had the experience of, after I persuaded the Hawaii Medical Association to support single payer back in 2009, I discovered that a lot of my support came from the procedural specialists because they recognized that my proposal would eliminate micromanagement of doctors by insurance companies. And they value their professional autonomy more than the income. And they were willing to accept standardized fees and to some degree restricting their total earnable income if they had their autonomy back from the insurance companies. And a lot of my strongest supporters were conservative, Republicans, procedural specialists. So I think it can fly.
Well, thanks a lot, Steve. Any other, one last question for Steve before we go? All right, we're adjourned. Thanks, everybody. Thanks, Steve.